I would just give a small context about DORI. So DORI basically is a dialogue on retinal insurance. A bit of a history of insurance in India was that initially when insurance coverages started, it was a hospital indemnity product always. Coverage for eye diseases, especially even cataract, was not in place. So the journey started from coverage of cataract, and then eventually last year in September 2019, there were standardization and regulations which IRDA had come out with, asking that now retinal, anti-VEGF treatments can't be excluded in the insurance policies. So the session is conceptualized about awareness on the insurance coverage, especially for retinal diseases. I would move ahead and have just project my slides. I will have a small round of introduction for all our panelists. I would like to introduce Dr. Himanshu Mehta first. He has more than 25 years of clinical expertise, and I think a 1 or a 2 minute introduction from my side would be really small, to cover that whatever he has done in his 25 plus year of clinical trajectory. His bachelor's and his master's is from India. He's had his practice in Mumbai, as well as he's a fellow societies, European academic societies, as well as American academic societies of ophthalmology. I would move on to Mr. Shantanu Saxena. He's our next panelist. Shantanu is an IIM alumni, and he's been into insurance consulting for more than a decade. He is the vice president and the regional head for Anviti Insurance Brokers, and he is responsible for conceptualizing and benefit designing, and also managing a lot of group mediclaim policies for MNCs and multinational corporates. A small introduction, I'll give him the chance to introduce himself again. We'll move on to Dr. Amit. Dr. Amit Kumar is a professional with more than 19 years of experience. His initial 5 years being completely into clinical expertise, and post which more than 9 to 10 years into health insurance, and in different sectors of health insurance, where he's been with health and wellness players. Currently, he is the associate vice president and takes care of the health risk management piece for Anviti Insurance Brokers in the northern region. We'll welcome Mr. Sushant Anand. Mr. Sushant Anand currently leads the market access for India Novartis, and he is a master's in pharmacy from Manipal University. Before Novartis, he spent his time in Dr. Reddy's as well as WNS Global. Since past 9 years, he's part of the Novartis family, and he's passionate about working on innovative solution to improve patient access. So, he will also talk about the work which Novartis has put since more than a decade to open up access to retinal patients, or retinal blindness patients, I would say. So I would welcome Dr. Himanshu to set the context. Dr. Himanshu, why do you feel that there was a need for insurance coverage for retinal diseases? And also, if you can give us a landscape or a setting of why it is so important that retinal diseases should be covered.
Thank you, Shraddha. Good morning, friends. Good. Shraddha, actually this is a no-brainer. If the engine of the car is not working, no point changing the windscreen. So if the retina is not functioning, how can the patient see? This is an absolute case of blindness. It is not that it was something which the patient acquired because of his bad habits. There's a lot of genetic component to it. There is so much to it that the whole society could be crippling with increasing the age group number of people surviving for such a long period of time. The problems that they face when they want to have their own freedom and they want to see the world. There is no reason under the sun that anybody had to fight for such a long time to have that covered by insurance. It is a birthright for people to see. If you are visually born with vision, there is no reason why this should not have been covered, because it's a huge thing. Here you put a lovely slide for me that that retinal disorders, AMD, diabetic macular edema, they are the leading cause of visual impairment in India. Not just India, but across the world, even in developed countries like the US or the European countries. The major cause of blindness across the world is actually diabetic macular edema or age-related macular degeneration. That's why so much of research, so much of work was done. I mean, I remember in 95, 96, my institute there, my boss, Dr. Charlie Garcia in Houston, was one of the guys who started with the study on the anti-VEGF. And this is such a huge amount of pharma dedication and across the world people who did this because we have to solve problems. We were looking at cataract from Sushrusha's days. The longevity was different at that stage. The longevity is different at this stage. So overall people know that cataract and glaucoma were disorders like they were responsible for loss of vision and that, but what they were not aware of that age-related macular degeneration. We never grew with time. We refused to change with time as newer diseases. We took it for granted that that kind of blindness was just but inevitable. Having said that, science found out newer avenues. Ophthalmology grew beyond doubt after the 70s from retinal side. Till almost 1974, we had no retinal detachment surgery. We hardly understood the retina. All the equipments we had, the fundus imaging, the OCT, all that came way later. And the insurance was lagging far behind because they were not understanding exactly what is going on. So the policies were made on the previous thing. But AMD needs immediate awareness and attention. Significant proportion of the age-related macular degeneration at early stage. We have a lot of young people also, and if left untreated, severe vision loss more than 15. The early treatment of diabetic retinopathy study, the ETDRS, formed way back in 91, occurs within 2 years. Now, this is not funny. If you could almost go to near legal blindness. ETDRS study was done way back for the diabetic retinopathy. And if you can lose more than 15, more or equal to 15 lines in the ETDRS letters, that is unfortunate. So the estimated wet AMD patients, 2.09 million, and the estimated diabetic macular edema patient, 3.64. So you're looking at a huge burden to the society, to the family, to the infrastructure, to the country on a whole. Estimated patients to 5.73 million. Now this is not a small amount, and this is on an average reporting, and this is going to increase because again I'm repeating, India is fortunate that we have a young population. The COVID scenario is helping us because we don't have those old patients like in New York and or in Spain and Italy. We have the young population of this country, but as we start aging in the next few years, the skewed graph goes there. We'll have a lot more patients who will be having macular degeneration, and it's not that it is restricted to people above 65. Now we are seeing that in even younger patients, and we don't even know the excess exposure to the screen time and the rest, how much is it going to affect us in the future. So if we look at that, cataract was 47.7% of blindness, glaucoma was say 12.3. These are the known factors. What we missed out was age-related macular degeneration, 8.7%. Corneal opacity is 5.1%, diabetic retinopathy 4.8%. Childhood blindness 3.9. But what we are really bothered is this 8.7 plus 4.8%. That is the one which is covering a huge number of people, and especially the elderly age group where they need support, they need care, they need to be taken care of. So the higher patients at high risk are of falls and depression. Now already with age-related macular degeneration, you have a lot of depression coming up. Post-retirement, suddenly they realize that there is a void in their life. They want to enjoy with their grandchildren, they want to enjoy their retired life, go in the field, work, be independent, not depend on doctors and or their children to take them out anywhere. If they can't drive, if they can't recognize people, if they can't see the depth of vision, it is an amazing amount of depression. As you can see, people, elderly age group who have been confined to their house in the last 7-8 months or because of COVID, huge amount of depression, huge amount of problems. And to top it up, if they can't even see their screens and they can't do anything. So the poor visual acuity leading to a fall in AMD patients, injury almost 74%, fall. And we've been taught when we are doing orthopedic in our residency days that a fall and a hip fracture in the bathroom was the classical end stage for most patients. and the bedridden things which happened for almost 6 months, intertrochanteric fracture, I remember. So that was one which was responsible. If they can't see the depth, climbing up the stairs, especially in societies, in areas where they have depth and the light is not very good, they don't realize the depth, they fall down. So that is more than 1%. Of course, laceration is, we are not worried so much about laceration, collisions, and some of them who want to drive, if they can't see clearly, they are just doing it by whatever means that they could so that they could be independent. They are a menace to their own self, their family, and to the people around. So anxiety and depression, just go back please. Yeah. So anxiety and depression prevalence in visually impaired elderly is depression 31.2% already. Already it is there. Anxiety 27%, depression 41.3. So increases by 125% increase risk. Increased prevalence in visually impaired patient, depression 158% and anxiety 145%. Now this itself can be a killer. There is no point. You're dying a death every day if you have these at that age. They cannot enjoy their lives. Next slide please for me. Thank you. So AMD has been correlated to mortality. Of course, it is related to mortality. I mean, 55% higher mortality rate among AMD patients, 60.1 versus 4.7. I have personally seen in my career that all those patients who rapidly deteriorate in AMD, somehow AMD is a representation to me about the quality of their heart, their brain, and the blood supply to the whole body. As I put it, aging is nothing but lack of blood supply. So it could be infarcts in various form in the brain, infarcts elsewhere in the body, in the heart, you can get a myocardial infarct. But the true fact is quite a few of these patients have deteriorated very rapidly when you can see that they keep bleeding. The eye bleeder is actually quite a representative to me as to how these patients are deteriorating in their life. And that is a fact. So the mortality, I would say, among AMD patients absolutely correlates to that. That is an indication from the eye. As the algorithms creep up on the AI front, the artificial intelligence front, we've been so far watching on diabetic retinopathy that we can pick up on diabetic retinopathy. But the moment we start getting those algorithms in a short while on AI, that those vessels affected, then the type of ARMD affected, which would also indicate the heart disease and the amount of brain problem that these patients can have. That will give us our newer graphs. So late AMD associated with mortality rate, as you can see that very clearly, that this is so amazing the way it just falls. Between the age up to 80, early AMD, what is the situation, survival rate, and late AMD? There is an absolute decline. There's a geometrical decline, as you can see. So this is what is in time after examination in months. If you can see in the early AMD 386, and you can see what happens further down as they grow down, and in no AMD and in late AMD, how badly it gets affected. These are pure statistics which can tell us without doubt that AMD is a disease which can give rise to a lot of problems in quality of life, quantity of life, in every which way that these patients need help and they need to be looked after. Next slide, please.
Dr. Himanshu, like one question. So now, after the coverages are in place, and plus, we know, from the context setting that how important it is to treat retinal blindness. The current coverage or the improved access to people who already have insurance, do you see that the physician's dilemma first to prescribe therapies which were expensive? What is your view on that? How has it helped the physician to prescribe approved therapies or therapies which are clinically researched and approved by the regulator?
Shraddha, you have touched a very important chord in my life. What you said is something very, very sad, that the poor physician makes no money on the medicine. The moment they are said, the doctor says it costs this much, they say the doctor is making money. Like intraocular implants. They think the multifocal is free of charge. The doctor is so free always. So even if the cost written on the injection vial, which is not available in the shops outside, the doctor has to supply that. And when he's doing that with minimum charges from his side, the patient unfortunately always feels that the doctor is charging money. This is the first part of the story. So insurance, if it is covered up, and there is always that poor guilt in doctor's mind that if insurance is not covered, why should I prescribe to the patient? I mean, we have no guilt. We are trying to give the best to the patient. What is available, what is passed by the US FDA or FDA across the world. Because tomorrow in the court of law, we have seen that very clearly. The judge is not going to help me if I use off-label medicine. The whole world is not going to listen to my 100,000 good patient that I did good work in good faith. If I have done good in good faith, the non off-label use of other medications which are being used rampantly because out of sympathy, the doctor doesn't do it because he likes to do it. He's doing it out of sympathy for the patient, so that at least some treatment, then no treatment, is done for the patient for the benefit of that patient. And in the bargain, he takes the brick batting because if there is some infection, if there is some inflammation, if there is something, and we have a noted case in the Supreme Court, and no lawyer will protect me at that time. Nobody will say that this person did out of good faith or he was a good Samaritan. The word good Samaritan doesn't come up for the doctor at that point in time, unfortunately. He is the one who's crucified and nobody can help you, no society, no consent is valid at that time. So if the insurance mentions clearly and they understand, the legal processes also understand that this is approved by the FDA and the insurance is not doing any favor by getting it and giving it to the patient. So it of course helps tremendously. Why should I be justifying for insurance? Every time the patient comes and asks me, Doctor साहब ये insurance में मिलेगा क्या? But I am not the insuring agent. Go and ask your agent. Your agent makes money from last 25 years. I am not the insuring agent. Why should I be reading laws on insurance? I am a doctor. I'm supposed to know my disease, my pathology, my treatment, my pharmacology. I'm supposed to deliver results. I'm not supposed to be knowing insurance. But somehow the doctor is the first line of firing. So every patient, relatives, chada on the doctor everywhere. That no, you tell us why insurance is not giving us. I mean, I have no reason. And if God forbid, even today, Shraddha, if we show this to patient that insurance is allowing this, and if they don't get it passed, they will first come and blame the doctor. Doctor, you told us that insurance will give, and how now insurance is not paying us. So it's a great problem for doctors. In good faith, whatever we say, we have no intentions for them not getting or getting it. I'll be more than happy if they get it. But this is where the position is. So it should definitely help us. And if you can give us these documents where we can support these patients, because most of the agents, believe you me, 99.9% of these agents are not doing their homework. They don't know what is allowed, what is not allowed. They don't know their job. They are just there to make that little brokerage which they make in their insurance. So they have to be told properly earlier on, and that is something very important.
Shantanu, let's move on to you. We've seen that insurance has a regulator where even doctors are regulated. Hospitals currently have no regulator as such in the Indian context, except for the wards or the states where there is a regulator for the registration fees. But what is the role of IRDA? How it governs the insurance sector and why there was a regulator's need in the first place to be there?
Sure, Shraddha. So first of all, good morning, everyone. So ideally, if you have to talk about the regulator's role in the insurance space, you have to understand that to get into insurance, there is a lot of financing side which is needed. And tomorrow, if you do not have a regulator, you can get into a space where you are taking money from the retail customers and not being very responsible for the payouts. So here, specifically, any financial sector, you need a regulator, and it works actually like any other regulator. Like we have in aviation, which is DGCA. In international markets, we have SEBI. So here also we had to have a regulator. And while India is amongst the most heavily regulated country in the world when it comes to insurance, but to a lot of extent, I think it has also done well for us. So the regulator needs to ensure that there is fairness in the overall distribution of insurance. And its primary goal is to ensure that there is enough penetration of insurance in the country. At this moment, I think we are sitting anywhere around 7 to 9% of penetration, which is amongst the lowest in the world, even in the developing world. And if you look at developed markets, they are sitting upward of 70%. So there's a wide gap that still exists, and with rising incomes and overall rising GDP and per capita incomes, we are seeing that there is a lot of awareness which is coming from the insurance side, and the regulators are also supporting and ensuring that we have new products coming in the market, and the insurance companies which are distributing are financially healthy and able to settle claims and queries for the customers. So that is the larger idea of having a regulator, and I think for this moment it's working well. Maybe going forward there will be certain relaxations that will come, and it'll be a little more of an open market. But at this moment, I think we do need a regulator, and clearly they are doing their job of ensuring fairness and reach in the market.
Shantanu, basically, what motivates, or I would say that what are the factors when the insurance companies think of, adding newer therapies or adding new indications per se, or any changes which needs to be happened? What is that like an insurer thinks? You've always you've been a person who have seen what happens at the insurance level, or even in the group policies or bigger policies where huge group or multiple number of lives are covered. What does it go into addition of a newer benefit or increasing any reimbursements per se?
So largely, Shraddha, very honestly, insurers they don't want to pay, right? So their first knee-jerk reaction to a thing will be that let's get this out of the scope of the policy. So unless and then there is that existential problem of fraud. And in the last so many years, I think there has been a lot of work which has gone into fraud management and ensuring that there is only genuine claims which are coming forward. And once they've got that trust of the hospitals and the consumers, gradually they're starting to open up with their exclusions. So the idea of exclusion is mostly coming in from a fraud protection standpoint of view. And then there is representation that is continuously happening from various sectors, including doctors when it comes to understanding of existing diseases, and then even the consumers are getting more aware, where they start to question whether an XYZ thing should actually get into exclusion or not, whether there is actually a locus standi with respect to factual exclusions, or is it just extending because nobody has thought about it. So thankfully representatives like you, yourself, and the Doctors Association and the consumers, people start to, the underwriters specifically, they start to look at their products, and then they also see that once there is a certain availability or demand of particular products, they start to incorporate these changes in their entire spectrum of product distribution. So largely that is how they look at designing their products. And if tomorrow there are and I'm sure there is advancement which is happening continuously. So there were at one stage there were only 10 daycare surgeries which were allowed, and now the list has moved up to almost 170. So there is a continuous evolution of the product, and basis both science and technology, and that what helps them design their newer products.
Shantanu, a small brief, overview, like, when people would look at just like inclusion. So, okay, now anti-VEGF therapies is included and it is covered. But, when you read an insurance contract, even for all of us, so when we take an insurance policy, when it comes to us, it's a 24-pager or a 22-pager. And do we really read every line of it or no? And so what is a standardized product which has come out? And even if there are inclusions, how they need to interpret it. So some bit of, so I have just captured, or we can just show as we are talking to ophthalmologists, so of interest, inclusions, exclusion, if there is any pre-existing disease clause. So I would request you to just give us a little bit of insight into that.
Sure. Yeah, I mean, it is an exhaustive contract, and for a layman, it becomes almost impossible to understand, what are the kind of coverages which are available. Everybody mostly will be, talking about major diseases, whether that gets covered or not. And the understanding of human body is, of course, very limited for a layman, right? And in fact, we, in our experience, see so much grayness even in the claims that come in that it becomes very difficult for sometimes even the underwriters and the TPA, the educators of the claim, to really understand whether something should go ahead and be paid, or should it, go under the exclusion. So, the retail setup, in fact, because if it is like an off-the-shelf product, there are limited things which get excluded. They are fairly well defined, but then, like we have a complex body, and the relationships can be, multiple. So there could be somebody having hypertension before buying the policy, or diabetes before buying the policy, and later developing a similar, disease which can be related back to both for example, a heart attack can always be related back to hypertension. And insurers will be more than happy to put it under a pre-existing clause and say that, we don't want to cover it. So owing to all of these confusions, there was a standardization step which was taken by IRDA, and I think it's a very good step that they have taken. This is how also, if you see in the West, everything is extremely standardized, like even the treatments are standardized, and the medicines also are pretty much, they know for which procedure, what medicines are to be given and what will get approved. So pretty much, that was something that I think was the need of the hour. And there were multiple standardization, inclusions that happened last year. I would like to focus specifically, of course, on the ARMD side, but then there was also inclusion on the mental health and, etc. So, I mean, there were multiple things that got standardized, and they were all falling erstwhile in the erstwhile contracts. It was usually excluded or not even mentioned. And anything that was not mentioned was usually, it would have a blanket exclusion that anything related with eye is an exclusion, unless you met with an accident. Or so anything related to dental is like a blanket exclusion, unless there is a 24-hour hospitalization. And in that case, a lot of, sometimes doctors and sometimes patients, they didn't know. And because of, less understanding of the product, what they would think is that if they stay in the hospital for 24 hours, they will get the insurance paid out. And then, unfortunately, they would get a root shock, and they will get decline, and then the entire problem will start again. So thankfully, after September 2019, insurance companies' contracts will by default cover, and again, I will only focus on the retinal side of it, that they will cover the IVT and they will cover any ARMD treatment. So while in the group product, ARMD was something that we were still seeking because we could see claims coming in. And I remember sometime in 2010 or 12, I think a single shot will cost anywhere around 80,000 to a lakh. I think, the cost is substantially reduced today. But at that time also, these were claims which were, for coming under rejections, and they were getting highlighted in our reviews with the management. And, there was this question as to why it's not getting paid. And of course, it was a painful problem for the employee, because he was like, 90,000 single shot is just too much for this to be not covered. So we had started to include that in our group policies, and thankfully now, it has also got included in the retail space. So this means that going forward, anything that is related to ARMD, and if the person is insured, then that will get covered, and that will make the entire process much easier with respect to continuation of the treatment, and of course looking at the financials, aspect to it.
Can I ask you a question, Shantanu?
So.
The question is, would that mean from the time they are insured, so 24 months prior to that, they should not have had it? Something very important. Is that what you're saying?
No, sir. So the 2019 effect says that from the time the renewal will happen of the policy, they will have the coverage starting from start of the contract. There is no pre-existing side sitting on it. There is no waiting period sitting on it, unlike the erstwhile policies, where somewhere you had 24 months, somewhere you had 48 months. So none of that will sit. For cataract, 24 months will still stay. And that is largely again from a claim control point of view, because they don't want to get into a scenario where somebody already knows that they have cataract and they buy a policy and tomorrow they can get that treatment done. But for ARMD, it'll be day one coverage. Of course, the coverage has been limited. So every insurance company is taking out their own product. And I think the minimum they are offering is the 50% of sum insured. In some cases, it's also 100%. And ultimately, of course, as the buyer, you should ask these questions. But unfortunately, we are not doing that. But ideally, for the coverages, the minimum will be 50% offered on day one.
So the contract is always unilateral, like a builder. You have no chance. Your guy, my lawyer cannot argue with the insurance company. So it's a unilateral contract. So it's always against me. Given half a choice, I will be out of the whole scenario. So that's a fact. It's unilaterally biased. So that's very clear about it. So you said 50%, but that means a lot of people. I mean, let me put it very frank. So somebody starts getting AIMD, needs injection. He takes a policy, but what you meant is he can be covered up from next month.
That's correct.
Okay, very important point that, indirectly, that if I have to read between the lines.
Yes. Yes, you're right. But then somewhere, see, as a doctor, you will mention it somewhere in the. I mean, it can't be that today you diagnose me with ARMD and next month I go and buy the policy and then get a
No, I'm
treatment.
just saying from the patient's perspective. I'm now talking like a patient, not as a doctor. Because
Yeah.
I am act of omission from my side. I have no idea when he took policy. I have no reason to ask all those questions. So I'm
Yeah.
just saying a patient does it, he'll still, like cataract is 24 months. Here there is no waiting period. That's all.
That's good.
Okay.
Uh, can I ask a question, Himanshu sir?
Yes, sir. Sorry.
Uh, is it suppose a patient has a policy cover of 10 lakhs and 50% of the sum insured, do you mean 5 lakhs for per year he can claim? So
That's correct.
in theory, suppose I'm injecting a product, anti-VEGF injection, which is the total procedure cost, say 65,000. And the patient requires, say, about 4 injections in a year. Would the entire sum be covered? So let's clarify that. Is it
Yes.
valid for multiple injections? Is it only valid for one turn? Is it valid for 50% of the total corpus? What exactly?
So if the product says 50% restriction, that means that for 10 lakhs, for 5 lakhs, you can use the ARMD procedure. And if that means that the treatment has to exhaust the entire 5 lakhs, then so be it. As long as it is the need of the patient and it is prescribed, for the treatment, it will get paid up till the limit. Even that means that's multiple injections.
Is the drug cost covered completely? And are there any cappings on the hospital charges, the surgeon charges within that?
So that will again come back to the contract. It depends if you have chosen to get restrictions in place, then there will be restrictions and basis which you will be getting paid out. So for example, if there are room rent restrictions which are sitting in the contract, if there are any other restrictions which are sitting on the contract, then they'll supersede this.
Okay. And one last question, is it applicable to only DGCI or FDA approved products? I believe so. It must be only
Yes,
for.
absolutely, absolutely.
Okay. But does it cover biosimilars also?
So I'm not a doctor, but from the broad understanding, I can tell you that anything that is approved by FDA, it will go ahead and yeah.
Suppose it is not approved by FDA, but a local Indian DGCI control body.
In
Because
that we will ask maybe Dr. Himanshu or Sushant to take that question. And also to the clinical aspect, if Dr. Amit wants to add a bit on the claims nitty-gritty piece. So Dr. Himanshu, you would be a better person, I guess, to take that, or Sushant would be.
Yeah, I think because, see, this is Swapnesh, we have to start with the idea that unless proved otherwise, it is going to be rejected. I start with that. With as far as the insurance company is concerned, their point of view is always going to be rejection.
Yes.
I put it, let me make it easier. The new MBA guy who's just got into that post, I tell this page to my patients, and I'm just telling it to everyone. The new MBA guy who's just taken up that position, he's going to get his 10 lakh extra bonus or $1 million bonus he'll get only when he saves money for the company. And the only way he can save money for the company by cutting patient and the doctor's amount. So let's start with that understanding and concept of life. That's how he gets, and the mother gets, and the father gets very proud that my son got a promotion and he's become now the senior vice president by saving money for the company. This is exactly what happens to them. Having said that, so they will not look at anything when it is, and finally, why are we answerable for that? Yes, for the point of argument, we should know that, and we should. I would ask somebody else also, man.
Sure. If I may pitch in, so I think as per the guidance, maybe not an expert here, but it clearly says intravitreal injection. So Dr. Swapnesh, that primarily includes all the approved therapies. That's the understanding we have. And I also would like to comment on what Shantanu mentioned. I think on the 24 months waiting period, it clearly says, and again, it's left to interpretation. Shantanu, you may be the expert here with the cataract and eye ailments. So I am not sure if the point you made earlier that from the next day of buying the policy, the intravitreal injection will be covered. I mean, that will, I mean, as Dr. Himanshu mentioned, I think at the end of the day, we have to understand insurance is a risk aversive business. So possibly if they have not got the premium, which is not claimed until now, I'm not sure if that would really work. That is my understanding as a layman, but you may want to double check that, because it finally says cataract and other eye ailments within the 24 months remit. So I thought I'll bring that point to the
So,
table.
I guess what Shantanu was mentioning was about particular policy of Arogya Sanjeevani, but otherwise, I think the interpretation would be if we already have the insurance policies for ourselves. Like, if, for example, if I have bought it like a 10 years back, 5 years back, or 6 years back. So for us now, from the renewal period, there is no waiting period, and it's
Of
covered.
course,
What
of course, sir, of
Shantanu
course.
mentioned was, I think he clearly said that, if like, for example, for a cataract or an ARMD, like I go to a medico and I get diagnosed and I buy a policy, I can very well wait for 1 month, 2 months, 3 months also, and then put a claim. So in that scenario, even if it is ARMD, which is an age-related macular degeneration, there will be a waiting period, which would be of 24 months,
Of course,
as
Shraddha.
it will be for cataract. So that is how it will be interpreted.
Yeah.
So
Thank you.
any disease which is already present while buying the policy contract is always considered as a pre-existing disease.
Sure.
And that the insurer knows from the history which the doctor gives. So hence, I think now when we go to Dr. Amit, he has, he'll tell us that what are different types of claims and what are the mandatory documentations which would be needed to have a claim adjudicated or processed, and without which it doesn't go through in insurance. So I think, Shantanu, in the context, looking at the time as well, I think it's very interesting discussion. So we generally overlook the time. I would want to call upon, Dr. Amit. There is only one thing which was there from your end, was that corporate and retail, how it is different. As when you look at the mix of insurance, we have 70% of our people who are covered in private health insurance as a corporate client, and the retail buyers, like all of us, or maybe it's just a 30% set which is there in the overall numbers when we look at the penetration. So what are the advantages of being a employee or a corporate employee, and if your employer is covering you, what is the way of fighting for your case? And if you are a retail person, then how is it different, and whom do you approach? So maybe a small
Yeah, so I'll be very quick there. Retail is basically a pre-designed off-the-shelf product. There is not much that you can alter with. There is a predefined price and predefined coverage, and basis that you as a consumer can choose. There are multiple waiting periods which are existing in retail products, and usually it is, for the first 4 years, I would say is largely to just ensure that there is accidental protection, or there is a big disease protection. After 4 years is when it becomes very comprehensive, and almost everything gets covered in the retail policy. A corporate cover is absolutely different. So because of course the quantum is very different, and the way the product is designed is that it's basically called a tailor-made product. So we as consultants, we sit for the clients, we tell them, what are the kind of coverages that they need to have in the policy, and basis that a premium is decided and that is paid out. And it will, of course, for large corporates, it will run in crores. So there is a lot of leeway with respect to the way the product is designed, the coverages are enhanced, and a lot of things which are not covered in a retail product will, have the option of getting covered in a corporate policy. Also, there is a full mechanism of brokers and the insurance companies and relationship managers. So tomorrow, if there is a patient and he is covered by his corporate, if there is any issue, then they can approach the brokers, they can approach the TPA, and there is a full mechanism of any kind of a query addressal scenario. Versus retail, where unfortunately, what happens, the access points are very limited, and the poor patient or the customer has no idea, who to approach, what to do. They will send in their, approval in the morning. They'll be sitting till the evening. They'll have no idea. Then they'll probably get a reject letter. And, there is very limited access point to understand the problem. But still, I think a lot of new insurance companies are trying to fix it and go digital. And they're trying to make this entire customer service and claim management much smoother. But largely, that is one difference that I still see, that with respect to the way it is serviced, a corporate customer, of course, has a lot of advantage with respect to both coverage and the way they will be attended if there is any query at present.
So so moving on. So now let's ask Dr. Amit. So as Dr. Himanshu earlier also said, so as a clinician per se, you have to treat your patient, but you also have to help your patient to get his insurance claim. The expectation is from both the sides. And when as insurers, when people sit at the insurance company or a TPA per se, what they are doing is they are seeing the document or a discharge summary or a consultation paper which is written by the clinician which comes to them. And they process the claim only on looking at the paper and not at the patient. So, Dr. Amit, moving on, different type of claims and per se, now what are the mandatory documents which, make it smoother for even the clinician and for the patient to file a claim, right?
Yes. So, first of all, good morning, everyone. And thanks for giving me this opportunity to speak on, claim process and how to pay out the claims. As everybody knows that there are two types of claims in insurance. That is, first is your cashless claims, then second is your reimbursement claims. And similarly, we have two type of products here. Like one is your group mediclaim policies, and second is your retail product, which individual purchased from an agent or from an insurance company. And in group mediclaim, generally employer purchase that particular product for their employees. So there are two different scenarios here. When we talk about group mediclaim policies, generally employer take that decision and they cover all their pre-existing disease and everything. In retail products, there are a lot of you will see the periods where you are not going to get the claims, like Dr. Shraddha said earlier, that we have a waiting period of 2 years in cataract and eye related claims. So similarly, those the waiting periods we are not seeing in group mediclaim policies. Here, when we talk about cashless claims, so every hospital kiosk have a checklist where they know what documents they have to retrieve from employee or claimant. So they know that they have to take a claim form from them, they have to take ID proof from them, they have to take a cancel check from them, there should be a proper discharge summary, a proper detailed bill should be there, doctor prescription should be there. The most important thing which we are lacking is the counseling part. So in my opinion, there should be a counselor in each and every hospital who can counsel those individuals, those patients about the policy, that this is the product, these are the coverages. Like we all know now that all MABs are covered as a modern or advancement of treatment from September 2019. But when you ask this question from a TPA kiosk person, might be he don't know about this circular. So he don't know what is, AMD treatment, whether might be he knows that what is AMD treatment, but he don't know what exactly in AMD treatment is covered. Like in some products, you will see there is a 50% sum insured covered for that AMD product, or full sum insured is covered in that particular product. So there are a lot of, ambiguity between products. So those, counselings are required for those hospital kiosk people. That particular counseling, that particular, information should be there at hospital kiosks, so they can completely know about the product. That if uh, any AMD person comes there and he asks what this is my product, and you let me know whether this particular disease is covered or not, so they can counsel that person that these are the documents which we require, and this particular treatment is covered up to this limit. These are the uh, documents which we need at the time of admission. So those counseling, those information should be there. In spite of the checklist, everybody have that checklist, what all documents required. The most important thing is counseling the patient. So there should be some protocol, some type of what we say training for those hospital kiosk person to identify gaps, and there should be a proper information in place for those claimants.
Sure, thank you. So basically, Dr. Amit, just this is, I think people can see on the screen, is the documents to be submitted. These are the
Right.
mandatory documents which would be needed.
Yes.
For a claims to go for a processing, and also then get reimbursed, right?
Right.
The thing is, let's move to this, where we always say that what is the healthcare practitioner's role. So we were talking about, yes, treatment and approved therapies to prescribe, how exactly they should go ahead. So if you can just have like a OCT should be there, or what exactly they need to do. So like a single liner prescription, would it go through, or just like a consulting sheet which is just has a name and the procedure date and what is to be done, that's it, and nothing else, like no pre-existing disease mentioned, or any history mentioned, or prognosis mentioned per se.
Yes.
Because historically what has happened is, especially in the procedures which are, I would not say a IPD or a operative procedure, but which can be done in the OT or of a clinician of an eye hospital or an eye clinic. Generally, it is go in, go out. We are used to it so much that we don't want to spend that much time to put everything through. Or even the counselors at hospitals, they come with the thought process of years together that, this is not done or this is not covered. But if it has to be covered, then what is that we need to keep in mind?
As we discussed earlier, that obviously we don't need a single liner thing. So we need the complete details. As everybody knows, the insurance company work on documents. So whatever you will see on documents, they will process that. So if you see the pre-authorization form of any company or any insurer, you will find that they had specifically mentioned certain disease for which they need the duration and the details. Like for pre-existing disease column, they had mentioned hypertension, they had mentioned diabetes, they had mentioned tobacco intake and all that. So a lot of columns are there which doctor has to refer, or the person who is filling that pre-authorization form has to refer, and they have to provide the complete details in that. So if we are not going to provide the complete details, again, you will get a query from the TPA doctors, because as I said that all the process is based on documents. So if documents are not complete, if the details are not complete, if the information is not correct, obviously TPA doctor is going to ask you more questions, where we will see that TPA kiosk guy generally irritated that this particular TPA asks so many queries after sending documents. But it's not like that, as we are also following some protocols as per laid by insurance company. So they follow that protocol. So they generally check all the documents, the disease duration, whatever disease is there, so that is covered or not. If they feel that the information is not correct, the information is not complete, so generally they ask the complete details or the documents supporting to that particular prescription.
Great.
Is the OCT report, somebody is asking right now, that
Yes,
is the
on the
OCT
chat.
report mandatory?
Yeah, for AMD like cases or retinal detachment cases, of course, OCT report is mandatory.
So very important point, Amit, you mentioned retinal detachment. Grossly, I can see it. Still, should I do a B scan to prove that there was a retinal detachment?
As I said, sir, any documents which prove that particular disease is there, so either it would be a OCT or something else.
Amit, a MS doctor writing down that there is a retinal detachment, and you want him to spend money
Sir,
doing a B scan. I'm just asking on a very simple, on a lighter note. What I'm saying is something very, very simple, but very important from our
yeah,
standpoint to understand.
yes, sir.
I think Dr. Amit, you can say, but sir, just one-liner evidence-based practice. I think we've learned
Yes.
a lot from other countries, so that is what it is.
So
But yes, Dr. Amit.
It's like Shraddha, you have a pre-existing eye. That's why you have an illness. So you will not be getting it. Because you have an eye, you have an AMD. It's like saying you can get a heart attack because you have a heart. So you had a pre-existing heart. That's why you have a problem.
So we can discuss it. I think I think Dr. Amit represents. So Dr. Amit, what is your take on this?
Act of God.
No.
That is not.
No, of course, sir, you are more knowledgeable person than a TPA guy or than a insurance guy. We are not saying that.
We are helpless.
So
We are helpless people. Let's accept it very clearly. We are most helpless from the TPA doesn't listen to us, the patient doesn't listen to us.
No, completely agreed, sir. Whatever you are saying. The only request is that if information is in a complete format, I think that will really help both of us. So it will help you also. It will help me as an insurer or a TPA also. So I think a proper information paper or the details will be really helpful.
So, sir, if I may pitch in here, I think of course Dr. Amit is the expert here. But I guess one of the, as you rightly said, Dr. Himanshu, I guess one of the key factors need to be observed that we are operating in a very fragmented space. If you look at India, how the health insurance really works, and possibly the regulator is there to give the guidance, but then as Shantanu also mentioned, it is really the individual contract of the companies that really how do they operate, what are their operational modalities. And sir, you will not be surprised in all the practicalities, maybe one accepts without the OCT, the other may ask for it. So I think what I'm trying to put across is that we may not have a standard answer, considering that we have so much diversity in terms of how each of these companies operate and their protocols, as Amit was referring to. So it's very fragmented, and I think having worked with multiple stakeholders for last 2 to 3 years now, one thing I can bring to the table is that there needs to be a lot of consolidation that needs to happen if it has to work anywhere closer to how reimbursement works in a developed world. But yeah, I mean, we are all aware we might not get there immediately. It's a journey, but at least there are things moving for expanding more and more inclusion from the regulator side.
And IRDA is the least accessible body from the patient or the doctor. It's a faceless monster for us. In last decade plus, whenever we had a meeting, it is some TPA person, IRDA, there is no answerability. We have no hierarchy there whom I can meet or talk to. There is no hierarchy. IRDA, unapproachable monster, who has said, Bhagwan ka naam se le lo abhi aap.
No, that's correct, sir. That is correct. But like Sushant is saying that there's a lot to be standardized, including the claim processes. And thankfully, we are moving towards it. We are moving towards it, and hopeful that in times to come, this will all better up.
And and
So,
sir, maybe one additional point I would say, I mean, don't disagree with what you're saying, but I guess additional point is that if you look at the whole business, as I mentioned, it's really risk aversion. Some people pool in money to pay for someone who needs it, and possibly with the current situation we are in right now as pandemic, maybe the penetration increases and there is lot more amenability even for the privately run organizations to possibly look at expanding the remit, considering the base increases with the focus on health, especially in the current
No,
times.
yeah, absolutely. That may also help, Sushant. In fact, if you look at the loss ratios for insurers, for every 100 rupee they spend, the losses are sitting at around 110, 115. So it's also not a very profitable scenario for them at the moment, and hence they are very stringent when it also comes to paying out claims, and they want to ensure that there are very less Dr. Himanshu who are sitting in India. I mean, it's a huge country, and there are enough cases where frauds happen.
Shantanu, sorry to break in, but I can just agree to disagree. Insurance is the largest investor in all stock markets. Insurance and pension funds are the guys who have money, are loaded with money. So when you say 110%, you are skewed only to the medical part. They are covering up elsewhere. So let's not me have any sympathy for them. They lose money in
No,
money
no,
markets, in currencies, they lose lot more money. So I have
not.
no sympathy for that. So that is medical health of the country. So it's a different
No, no, I
scenario.
have no sympathy for them, sir. The good thing is I also represent the client, so I am
I know. I'm
always
just kidding. I'm just
working
trying
on
to tell you that we
the client
they
interest.
put us a sorrow figure that medical insurance is like that. Having said that, all the huge money that is there in the Edinburghs and the New Yorks and the Hong Kongs of the world is all in the stock market and the pension funds. So
No, you are absolutely correct, sir, because after, during this pandemic, a lot of things change, which is not changed from last 20 years. So a lot of medical underwriting is going on. A lot of new products are coming. So now
a
they are.
consumer is a product. Poor guy doesn't know what he's in voting for. And Sushant said the perfect word three, four times: risk aversion. The poor guy is getting insured, but actually the company is making risk avert. कि boss नहीं मिलने वाला अभी तुम्हारा problem. This is I'm just talking on a very normal ground. Please don't misunderstand me. I'm not
so
talking
we
against anyone, but so we have to start and prove all documents that you are not going to get it. And Amit said so rightly that please put every paper that you will get it. So the
yeah.
more document that you put in, the more easier. That is a very
More
important
easier.
point that you mentioned, Amit. Yeah, I agree with you.
So, Shant, we can have insights from you. So, it is going to be like a year or two down the line, still a thing of discussion, like what will go through, what will not go through, because it is currently new. The coverages are just going to be there from this year onwards. So, would you just quickly, and then, we have some 4-5 questions to be answered, and I think we'll take 3-4 more minutes, and then Dr. Himanshu can close. But I would request if we can have 5-7 minutes to then take Q&A as well. Yeah, Sushant,
Sure,
please go
sure,
ahead.
sure. I'll keep it really quick, conscious of time. So I just wanted to thank all the panelists and the audience here. I think as an organization, we have been really working towards this coverage, and possibly a multi-stakeholder advocacy effort has really made this happen. Most importantly, really looking at how we create awareness among relevant stakeholders, uh, putting across the health economic rationale of coverage, which would ultimately decrease the upstream cost, as Dr. Himanshu alluded earlier. Possibly with geriatric patients, they may be paying right now 5 times the injection cost when a patient is admitted for a hip fracture or a surgery because of fall. So I think all of that we also brought in light to the relevant stakeholders, and I think now, of course, the impact is that with the standardization policy, with launch with effect from 1st of April. We have the intravitreal injection categorized as one of the non-excluded category in the modern treatment. And of course, as other speakers already mentioned, we have all the existing policies with effect from 1st October covering intravitreal injection for age-related macular degeneration. So what would really change? Maybe to sum it up, Shraddha, the next slide, please. So I believe it will make possibly the access more and more possible to the patients, possibly reducing, and as Dr. Himanshu earlier mentioned, possibly helping in reducing the dilemma of using maybe not using something and using something which is probably not up to the mark, but honestly the physician at times may not be left with the choice. So we definitely hope that this will increase more and more access to the approved and innovative therapies. And most importantly, maybe to repeat what Dr. Amit said, it we do understand and acknowledge that the change will happen over the course of time. And as it's been, say, a month and a half, we've seen this inclusion. Already we've seen few positive cases for the overall reimbursement, but I guess over the course of time, things will do stabilize, and possibly we'll get more and more clarity from different companies operating in this space, ultimately leading to better health outcomes for patients, not only helping them to get onboarded onto the therapy, but possibly uh, having a sustained compliance, which is also required if you look at the remit of macular degeneration diseases. So I just want to thank everyone for the opportunity, and I just want to close with an important disclaimer that as we have been discussing, just to summarize it, the acceptance or rejection of any claim is really subject to the specific policy terms and conditions between the insurance company and the policyholder. So I think that is a legal contract which is binded between both the parties, and with the fragmentation, as I mentioned, involved, we do expect that it will have its own streamlined curve over the course of next few months. But hopefully, I think we'll get there. So thanks everyone for the opportunity again. Back to you, Shraddha.
We'll take some 2-3 questions really quick. One of them is about the Arogya Sanjeevani policy. That if does a retail customer have to pay extra for it, or is it available with all insurance companies? So maybe not wasting more time, but a quick one. That an Arogya Sanjeevani policy is a standardized health insurance product which was launched on 1st of April 2020 by all the insurance companies in the market, close to 30 insurance companies. It's a standardized product which was designed by IRDA, and it was mandated that every insurance company makes it available to their customer. So it is a retail product available with every insurer, and it is going to be the same for every insurer. So people can buy that, and I don't think they need to pay extra for it. The second question would be, there was one question, they say it's out of context, but are the VR surgeries or the retinal surgeries also covered? So that is the question. Maybe the person has mentioned that it is out of context, but Dr. Amit, I guess, you can take that about the VR surgery coverage.
No, not after 20, immediately after the insurance.
Right.
What he's saying is without any latent period.
Okay. So I think Dr. Amit, you can answer that question, and then maybe we can add.
So as you see that they are not covered immediately after the coverage. So obviously it will take 24 months, and after that they will cover cataract and some eye related problems. So that is for everyone. Here I want to clear one more thing. We are discussing about the biosimilar products also, so that biosimilar products also are not covered in insurance policies. So I have seen a lot of rejections for biosimilar products also.
Amit, the question actually was retinal surgery. Retina is an emergency. Cataract may be an ongoing process. The question was, if you get a retinal detachment within 1 week after buying a policy, incidentally, is it covered, not covered?
So, Dr. Himanshu, there is one thing, there's a 30 days waiting period when you buy a policy, except for emergency accidental. Post 30 days, anything related to the eye retina which is not linked to a pre-existing like a diabetic retinopathy or a ARMD which is pre-existing in nature, the coverage should be in place. Dr. Amit, please correct.
And yes, one more thing here. If that particular retinal detachment is because of some accident, like there is a history of fall from stairs or something else or some accident, then again it will be covered. But when we talk about the normal scenario, in that case it will again covered after 24 months.
Emergency coverage is from day one. That's how it mentions. Yes, so I think we've covered maximum. There is one question on all anti-VEGF and Ozurdex covered or no. So I would not be able to comment, or I don't know. So Dr. Himanshu, maybe for you, because as we are not aware of the
all anti-VEGF. The answer is given clearly, whichever is FDA approved.
Thank you.
That should be the answer to that. And Ozurdex, if it is covered, yes, it should be covered of that, because actually Ozurdex doesn't come under the category of anti-VEGF. So if you are saying anti-VEGF, then this doesn't come up. So I don't have an answer to that. The company should be having on that. So I'm sorry.
All right.
So there is one important question from this webinar is supported by Novartis. So which companies are giving retinal insurance? Though IRDA has taken out a letter, are there only still specific TPA companies which are going ahead with this policy, or it is a mandate for everybody to follow it?
Dr. Amit and Shantanu, you can take that question. So, yeah, go ahead, Dr. Amit.
We are talking about Arogya Sanjeevani here?
No. Retinal injections.
Yes.
Though IRDA has taken out a letter on 1st of October.
Yeah.
Is it that only few specific insurance companies are giving insurance for retinal injections?
No. This is for everybody. This is for all 34 insurance companies, and TPA has to follow that instructions.
Okay. So it's not just private or a Bajaj or something. What is
yes.
Public insurance,
everybody, all 4 PSUs and all private.
Okay. And Dr. Malpani had asked a question: Is the binding law for the existing insurance users are only people who are going to now buy or renew a new policy, or is there a provision for any top up that they can buy if it is not already covered in the insurance their document?
I think a lot of top ups are there, so they can take for that coverage.
Okay.
Top-ups will also still will be governed by the basic.
By the base, yes.
So it's not that because you've taken a top-up, so now you'll have day one covered. The primary terms and conditions.
If I'm not mistaken, top-up means if I'm covered up for X amount, 5 lakh rupees, and my bill comes to 7, then the next 2 will be paid up. That doesn't mean that new disease is covered up. Am I correct?
Yes, you are correct, Dr. Himanshu. You are absolutely correct. So maybe to give more clarity, this 1 year you would see as and when our retail insurance, so we go for renewals. So when the renewed policy will come, it will come with the changes.
Okay, understood.
That is there. And people who are buying new policies from say today, day one, then whatever the policy contract has, the coverage will be in place. But depending on the kind of premium or kind of top-ups which we say, or I would use the word topping, like when you buy an ice cream, you have toppings. So how the toppings are charged. If your insurer is charging for it, and if you have a 24 months waiting, you have a 48 months waiting, or if you pay more and it is covered within the first year, that will be written in the contract. But yes, they can't exclude it completely. That is the regulator which has told them. But insurance companies can provide the product and design it as they want. So there is no mandate by the regulator on the designing per se.
Great. I think I will request Dr. Himanshu sir to close the session, and we'll start the clinical part quickly.
Yeah. Just a point, Shraddha. That means if you have an old policy, but you are still covered, Shantanu or Amit, if you have an old policy, it does not cover you originally in the document, but the directive is there from IRDA. So are you covered?
On the renewal, it gets covered.
As of now, it is not covered. That means.
So only on the renewal, very important point. So this clause cannot be cited on your previous document.
That's correct.
Oh, very interesting point. Very interesting. Which means we cannot tell patient because of your, unless your new policy comes up, this is not acceptable.
So it's almost a year since then. It's actually more than a year. So very less chances that there will be anyone who will not be covered.
Thank you, Shraddha, for coordinating such a lovely event. Very important, because every day doctors are faced with a tremendous dilemma with the insurance queries, and they have no idea that we are not used to signing any documents and understand. It's like on your Apple iPhone, every app you download, you just say agreed, because you'll never know into the details of those documents. And thank you, Dr. Amit, for shedding some great light, and Shantanu.
Thank you so much, sir.
It's a pleasure. Absolutely, we'll come back to you because these are queries which are always there, and we're very important. That we understand these things so that we can give the best justice to the patients. And
Right.
Dr. Anil, Dr. Swapnesh, thank you for being there, and thank you for inviting me for this very revealing session. And it will be very helpful for patients in the long run, because there has been so much of gray zone and a lot of understanding. Simple thing allowed. Make your documents cleared. Patient will be happy. Sushant, great inputs from you also. Thanks very much. Thank you very much, Shraddha, for inviting.
Thank you. Thank you.
Thank you, sir.
Thanks, sir.
Thanks, everyone.
Thanks,
for the
everyone.
opportunity.
Thanks.
So now I invite Dr. Prashant Bawankule, sir, for a clinical talk, and his topic is addressing the dire need in neovascular AMD, optimize treatment and lower the burden. Dr. Prashant Bawankule, sir, welcome and thank you for attending our webinar and giving your expert comments on this topic. Sir is a very well-known figure and he needs no introduction, but just for the people who have joined in, he has been a past president of Maharashtra Ophthalmic Society and Vidarbha Ophthalmic Society. He is presently the treasurer of Ocular Trauma Society and the joint treasurer of VRSI. He is also an elected member of West Zone ARC AIOS. And thank you, sir, for taking out time. You are busy with so many webinars, and thank you for coming to BOA.
Thank you, Swapnesh, for those wonderful introduction and kind words and the invite as well. It's my privilege to be with you people at a BOA forum as well. So let me start sharing my screen so that I can come to. Yeah, is it visible? My screen is visible now?
Oh, sir. Yes, sir.
Yeah. So good morning, dear friends. And here we are coming back to the clinical after learning where we can inject, how we can inject and still not have a pinch to our patient's pocket. Let's come back to when should we inject and how do we inject and when do we inject. So this is about the addressing the dire need in neovascular AMD management. Almost 200 million people are affected by various forms of age-related macular degeneration across the world. And we are aware that out of this, almost 85 million of them, 285% of them are because of dry AMD. Only 15% happen because of neovascular AMD. But this 15% is responsible for the most severe loss in 90% of the patient who has lost their vision because of age-related macular degeneration. Yeah. Yeah, so this is a disclaimer. We have moved as a retina specialist. We have seen the evolution of the treatment in 1980s when we did not have any form of treatment. And the moment we saw neovascular AMD, we would tell the patient he's meant for doom. Then came the 90s when we started doing some thermal treatments in the form of thermotherapy. And then came the PDT and then came the anti-VEGFs in 2005. Yes, anti-VEGF have become a mainstay in the management of neovascular AMD. And today as a retina specialist, we have in our kitty a lot many molecules. But the basic challenge still lies to us as a retina specialist. And this we need to understand why. We have very well understood that resolution of fluid and reduction in the central retinal thickness results in superior visual outcomes. This is our experience of last 15 years for us as having injected. But yes, sabse bada rupaya economy has more relevance, and we believe that the Number of injections might be less only because of the financial aspect, but the various studies have shown that economy need not be the only relevant factor. So what are the unmet needs which limit the outcome of neovascular AMD management? Let us try to understand. These are the existing real world challenges in management of AMD. Current treatment paradigm in neovascular AMD has shortcomings, not only in the form of compliance, but also efficacy and treatment burden. Stable increase in visual acuity can be achieved with continuous fixed interval anti-VEGF intravitreal injections, which we have seen through various hallmark clinical trials, not only with ranibizumab, but also with aflibercept. But unfortunately, in real world studies, the dosing is the biggest challenge, because in all the studies which we have seen with hallmark clinical trials, it is a monthly injection which gives a good drying and a good visual acuity, while in real world scenarios, on an average, patients receive less than 4.3 to 6.9 injections instead of 12 injections, which they should be receiving. Other challenges, if you see, AMD is on a rise to almost 200 million people across the world are suffering because of this, and they are consuming almost 0.5 to 0.6% of total health expenditure, and that too in European countries. Our country, where the health expenditure is so minuscule, we have no such provision. If you see these various trials, right from Marina to Anchor to Harbor studies, on an average, every patient who receives more than 12 injections, the visual gain is as high as 11 letters, 7 letters, 8 letters. But in real world evidence, these are the studies which are conducted in real world evidence, real world scenarios, where you can see on an average, the patient has received as less as 5 injections instead of 12 injections. And therefore the visual gain is unlike the scene where you receive monthly injection. Though we well understand that maintenance of visual acuity is definitely related to treatment intensity, but in spite of that, anti-VEGF treatment in clinical trial setting demonstrate good efficacy, but the burden in real practice limits the similar usage. Again, these are from European countries, where the number of injection instead of 12, where economy does not come, still does not match 12. It is less than that. 6 injections in Italy, in UK 9 injections, Netherlands 8.7 injections, France 6.3 injections. So in spite of having deep pockets, these people, because of various reasons, the patient are not compliant and do not undergo the necessary 12 injections. Visits and injection frequency decreased during the second years is all we have seen from various studies, which we don't need to tell. And this is the real world clinical practice. Observation from another post-approval studies, that is WAVE study, has shown that outcomes may be suboptimal due to underdosing. During the first year of treatment, an average of 7 to 8 injections are required as per CAT and EVAN study. However, only an average of 4 to 5 injections were actually administered to these patients. And now, if you have seen the European context, now coming back to our own country for wet AMD, these are the number of injections on an average, less than 6 injections in first year, less than 5 injections in second year, and the compliance further decreases further down as the disease progresses. So what is the reason? What is that as a retina specialist feel that longer acting molecules should reduce the burden? And this is the study from across. This is doctors' feedback from African, Asia Pacific countries, Central South American countries, Europe and United States. Across the board, the understanding is that we need a molecule which has a longer acting effect, so that the patient needs number of injections can be reduced, and that can help in reducing the burden on the patient. These were the molecules, that is aflibercept, bevacizumab and ranibizumab, were available in the kitty of our retina specialist as an anti-VEGF molecule in management of AMD. And lately, now another new kid on the block is brolucizumab. So does it really offer anything more than the previous 3 molecules which were in our kitty? Let us try to understand the basics of it. The molecular weight of this particular molecule is only 28 kilodaltons. Compared to the other things like bevacizumab, it is 149 kilodaltons versus ranibizumab, which has 48, which is twice the size, while bevacizumab is almost 6 times, and this aflibercept is almost 4 times more. So the number of molecules which can be injected while we are injecting it inside the eye can be more packed. So that is why, because of the special design, brolucizumab has least molecular size and highest molar concentration per injection, because within a particular volume you can pack in more number of molars of a brolucizumab, simply because the molecular size of this particular size is less. So this is the exact molecule which you can see. This is a single chain antibody fragment, SCFE, what we call full length antibody. These are the two components, FC domain. This is the part 2, Fab domains are there. And these are the specific receptors, variable domains, which you can see over here, which go and bind to the patient's cells. And thereby that is the VEGF. Because of the smaller size, the Paganex or brolucizumab has better penetration across the retinal layers, and this is demonstrated by the penetration time it takes. Brolucizumab, it needs only 1 to 6 hours, while ranibizumab needs 6 to 24 hours, while aflibercept more than 12 to 24 hours. And the ocular, in spite of having such a rapid penetration, the ocular half-life of this molecule is more than aflibercept and almost equivalent to that of ranibizumab. So that means the molecule reaches the target organs more rapidly, and in spite of being smaller, is able to maintain the half-life for almost a similar time as that of a ranibizumab. Importantly, it also has a stronger anti-VEGF affinity to the iso-VEGF sites. It means if it is more strongly bound, it will be neutralizing the VEGF for more longer period of time and in a better way. This is as you can see, if you compare it with aflibercept, 21 versus 46 at various temperatures, body temperature, you can see it is definitely more than aflibercept. The C study, which enhanced drug delivery within 6 milligram dose, translates into longer duration of action. This is what we learned from this. While the Osprey study here, what we learned is better fluid resolution with brolucizumab during quarter, that is 8 weekly treatment molecule. When 8 weekly dosing was done, still it had a better fluid resolution. So what we understood from these two studies was that C study we studied was more drug per dose with 6 milligram dose translate into longer duration of action. And this we could achieve more than 8 weeks. While with Osprey study we understood that potent fluid resolution achieved with brolucizumab is better than any other anti-VEGF molecule. The landmark trials, that is the Hawk and Harrier study, was done, which was a head-on comparison. And the difference is the countries where this study was done. And the trial data demonstrates that more than 50% patient maintained 12 weekly dosing and could achieve a great drying and a good visual acuity outcome. So treatment agnostics analysis of fluid and BCVA in the maintenance phase also revealed that it had a better retention and better activity. Regarding the type of a fluid, whether intraretinal fluid, subretinal fluid, or a pigment epithelial detachment volumes are all relevant. And these are all relevant, important to study how they resolve with brolucizumab. They have definitely good outcomes in all these studies. And naturally, if you achieve a good drying, you have a better BCVA. So lower fluid volumes in all compartments are associated with better BCVA is very well understood and was very well proved by these particular studies. So to summarize, the basic unmet need for a retina specialist and as well for the neovascular AMD patient is that the compliance and the need of less dosing. Visual outcomes do not translate into real world due to reduced injection frequency compared to clinical trials. And therefore, patients with higher fluid demonstrated reduced visual acuity compared to lesser baseline fluid. There is a need of having lesser frequent dosing to improve outcomes. And definitely this new kid on the block, that is brolucizumab, has smaller molecule which allows better penetration and a better durability and better fluid resolution, seems to be a big promise in meeting the unmet needs of these patients. Over 50% of brolucizumab 6 milligram patients were maintained on 12 weekly dosing interval immediately following the loading dose until the 48 weeks. Thank you.
Wow.
Thank you, sir. So, Prashant, sir, I would like to ask a few questions. So, do you actually counsel your patient for treat and extend regimen now directly, or do you still consider PRN in some cases? What is your take on explaining the regime to the patient with all this new data?
See, for me, brolucizumab, I have an experience of hardly 3 injections. So, frankly speaking, I am not. And in both, in one of the patient, it was just a treatment naive where I initiated the treatment. And in one patient, I have initiated as a alternate because that was appearing resistant to the treatment of aflibercept. So there I had a switch. So I really don't know. Frankly speaking, I am also keeping my fingers crossed and waiting for Nishikant to guide us because he's the rather a leader in the usage of brolucizumab. And yesterday also we had one of the webinars where I was listening to Dr. Pawan Singh,
Pankaj Singh.
Pankaj
Dr.
Singh
Pankaj Singh.
from Germany. Dr. Pankaj Singh, who had an experience of 200. So everyone is trying to they have an experience of 200 injections since April. So they were trying to, many a times they have switched to directly not treat and extend, directly right from, instead of loading dose, they have moved from first injection to directly 6 weeks, 8 weeks and all. So, but treat and extend would be the way I believe in such cases in future.
So, Borse, sir, your experience with the same molecule so far? Or your
So,
history
it is very early. I mean, we have just got the molecule about a month and a half back. So it's very difficult for us to say how it's going to fan out. But with this molecule, I feel treat and extend is going to be the way. Definitely. We will have to, I mean, I will show you the Hawk and Harrier trial. And I think in clinical practice, this trial is, I love this trial because we can actually replicate it in our day-to-day practice. And I will show you in the details how we can go about it. So it's a beautiful mix and match of treat and extend plus PRN. And if we follow the trial, I think we are going to get the perfect answers.
Okay, sir. So without much delay, sir, we can request you to start your presentation.
Yeah, sure. Thank you, Swapnesh.
Thank you, Prashant, sir. I request you to stick around.
Yeah. I'm there with you.
Borse sir requires again no introduction. I think most of us have already listened to his multiple talks, and every time I see his presentation, the video of CRAO comes to my mind, and which has won him so many accolades. Very senior surgeon from Mumbai. Actually, now he is a second opinion surgeon. So all of us send him patients for second opinions, which we cannot manage, and it would be a pleasure to hear from him.
Thank you, Swapnesh, for a wonderful introduction. So let's see a bit about what this molecule is. I'm not going to dwell much on these slides because Prashant has beautifully covered that there is a lot of unmet needs, and the unmet needs is not just the number of the economy, but even the number of injections. And that's why even in developed countries where they have a lot of insurance coverage and they don't have to pay out of pocket, the number of visits are less. So we definitely want some molecule that will give us a lesser visits and also cost lesser. And that's why we want a molecule that lasts longer, that will reduce the number of visits and reduce the treatment burden for patients. And that's where we feel the answer might be. Now, brolucizumab, or Paginex as it is now marketed in India, was basically started as a molecule called RTH258, which was actually made by a marvelous engineering. And I'll just go a bit more on the detail of that. So if you look, this is the single monoclonal antibody, which has got this Y fragments, and these fragments are the active areas, and they have a light chain and a heavy chain, and these tips are the most active part of this monoclonal antibody. So what they have done fantastically is just taken out this particular fragment and made it into a single chain fragment. And on the single chain fragment, they have mounted novel CDRs. These are the complementary determining regions, which are the novel CDRs, which have actually mounted on them and made them into a high anti-VEGF binding sort of a molecule. And this very light and very high chains are then bound together by a proprietary protein. So you can imagine it's a marvelous engineering. They have broken down this, taken out only these fragments which are important, taken out the CDRs of the original molecule and mounted another CDR on top of it, which has got a high affinity for anti-VEGF, for VEGF. So that you can understand that a lot of thinking, a lot of engineering has gone into making this molecule so that we get a very small molecule like Prashant has said, and in a single injection we can put in about 11 or 12 of those, which will give us a lot of action, very potent action, and more penetrability. Now, the basic trials which were done for approval of this were the Hawk and the Harrier trial. And we know that for any European or US market, you need to have two parallel trials which are done. One was a Hawk, which was done in United States and few places outside, but none of them had a European center. And the Harrier trial was basically a global, excluding the US. And these trials were basically phase 3 randomized trials, which are about 408 study sites. Now, these trials basically had treatment naive cases, and they were studied after injection of brolucizumab, and it was matched with aflibercept, which was the molecule used to know whether it is non-inferior to aflibercept. Now, as this study was done, they went on assessing the disease activity. So here what they did is they gave 3 loading doses at every month. So 12 weeks, the one injection has been given every 4 weeks. And at week 16, they saw very much like the way we do in our clinic, you see after 1 month and see whether the best corrected visual acuity has increased or not. So if the BCVA had reduced, or we found that the central macular thickness is not reduced as much we wanted, and if the investigator thought the disease activity is not come under control, then they said that let's continue injecting at every 8 weekly and not shift to 12 weekly. But if there was no disease activity, then a 12 weekly injections were done. But they continued to assess at every 20th week, 32nd week, and 44th week, and so on and so forth. And whenever you found that there was a disease activity, then the patient was shifted to a 2-monthly injection and not continued on 3-monthly. And when the patient went to a 2-monthly injection, he was kept on 2-monthly and never shifted back to 3-monthly. And this is what we should also keep in mind when we are using this particular molecule. Now, this is just a concert diagram for Hawk and Harrier. Let's not delve into the details, but this is how the program was. Okay, so a monthly injection was given at first level, and then after 4 weeks of the 3 loading doses, a disease activity assessment was done. And if the disease was active, then even the brolucizumab arm patient went into 8 weekly injection and was kept there. The aflibercept match phase continued to be on 8 weekly injections throughout. And then these 2 arms were compared. So this is the usual study design. And at every time, 16 weeks, 20 weeks, 32 weeks, the disease activity was assessed. And if there is disease activity was there or the visual acuity was dropping, then the patient was shifted to a 8 weekly and not maintained on 12 weekly. So why it was done so was basically for us to know whether this molecule was inferior to aflibercept in terms of controlling AMD. And how do you know that the AMD is controlled is by having a visual acuity gain, which was whether it was comparable to aflibercept or not. And on OCT, whether we found there was no fluid, because we know if you see fluid on OCT, then we say that it is equal to the disease activity. So it basically wanted to compare aflibercept and brolucizumab in terms of visual acuity gain, in terms of drying up the retina, and also to know how many patients we can actually keep on 3-monthly, because that's going to be the most important thing for us way forward, whether we can keep our patients at 3-monthly. And one more thing they wanted to know is to predict which are the patients who will go to 3-monthly, which are the patients who would rather like to be on, we rather like to keep it on 2 monthly injections. So let's see the main findings. I'm not going to go into the details and intricacies and confuse everyone on that, but let's just see one thing. Hawk trial, which was in US, had 3 arms: brolucizumab 3 milligram, brolucizumab 6 milligrams, and aflibercept. Whereas the Harrier trials had brolucizumab 6 milligram only and aflibercept. And what was found that by the end of week 96, the brolucizumab arm, which was either 3 monthly dosing or 2 monthly dosing, and the aflibercept were not inferior to the aflibercept arm. So the brolucizumab arm had a same amount of visual acuity gain as compared to the aflibercept arm. Now, the patients who got more than 15 letters from baseline, or a BCVA of more than 84 letters as week 48, we find that in Hawk, 33% of the patients gained 15 letters or more at week 48 as compared to 25.4 in aflibercept group. And in Harrier, we find at week 48, the percentage of patients who gained more than 15 letters was comparable between both the groups. So what we know is that this molecule works as good as aflibercept, whether you use it at 2 monthly or 3 monthly dosage, and aflibercept was continued as 8 milligrams. Now, where did the main difference between both come in? The main difference came in when you look at the OCT. So when you look at the OCT, what happened is the brolucizumab arm gave you sort of a prolonged drying effect without the fluid coming in between. Like in other agent like aflibercept, there was a seesaw pattern. So the fluid collected, you gave the injection, the fluid went down. Again, you gave the injection, again the fluid went down. But in a brolucizumab arm, there was sort of a proper drying which maintained throughout. And that's the same thing that you can see that happened even in the Harrier trial. So what it meant is that the brolucizumab has a better drying effect. And we know that better drying means less intraretinal fluid, less subretinal fluid, and less sub-RP fluid. And all of these translate into a better visual acuity as per scientific reports done at various stages. Now, how was the drying? Let us see. If you compare both of them, you will see that brolucizumab had a better drying effect as compared to aflibercept in terms of intraretinal and or subretinal fluid. Now we know that of all the fluids that we get in an AMD, the intraretinal fluid is the most destructive because it gathers in between the retinal photoreceptors and it damages the photoreceptors, gets them disorganized. So this molecule had a very good drying effect as compared to aflibercept, and it got rid of intraretinal fluid and subretinal fluid very well. If you just look at subretinal fluid also, you will find that there are superior anatomical outcomes of these molecules where the subretinal fluid had a better drying as compared to the aflibercept molecule. And that was not only on week 16, but it was at week 16, week 48, and even week 96. So up to nearly 2 years, we go on getting a good amount of drying that is going on. And the same thing happened when you look at the fluid which was sort of collected under the retinal pigment epithelium. So in a gist, brolucizumab, how different it is from aflibercept is the drying was good, number one. Number two, it had a mixture of patients who were 2 plus 3 monthly injections, whereas aflibercept was only a 2 monthly injection. Now, how many percent of patients were on 3 monthly injection? It was about 50% of the brolucizumab patients were on 3 monthly dosing until week 48. So you can say that nearly half of our patients can be converted into 3 monthly injection, and you can imagine the amount of burden that will come down for patients if you don't have to give it monthly, you don't have to give it 2 monthly, but you can give it once in 3 months. Now, how do you prognosticate which are the patients who can go for a 3 monthly dosing? So it is like if your first 3 monthly interval is completed without the disease activity coming back, then you can say that 80% of these patients will complete a 3 monthly injection up to 1 year or nearly up to week 48. So if your first step of 3 monthly injection gets good, then you know you're good for 3 monthly injection for the first year. And if you complete the first nearly 1 year, that is week 48, then about 75% of them are going to be on 3 monthly for the next year. So, they're going to just need about 4 injections for the next year. So this is the probability data that we also got from the Hawk and Harrier study. So this is the same slide with Prashant that I've shown. So it is a visual acuity gain where similar to aflibercept, it was a longer acting one. We can have a longer duration, lesser amount of macular fluctuation because of the drying effect being better. And we know that at least 50% of our patients can be made into 3 monthly injection. Now with that, I was lucky enough to be one of the first person to inject Pagenex in India. And this was a patient of mine who was a 67-year-old male who had diminished vision since 10 days, and he had a large subfoveal CNVM with a subretinal and an intraretinal fluid. You can see a lot of RP undulation. And I gave him injection Pagenex, and you can see within 10 days his visual acuity had improved. The RP undulation had gone, and you can see a drying effect. No intraretinal fluid, no subretinal fluid, no subretinal fluid at all. RP undulation becomes less. So the drying effect was just too fabulous out here. After 1 month, however, he comes back with some amount of subretinal fluid. And this is where I would like to stress that the trial has said that monthly injection for the first 3 months, and I believe that because you need 3 injections to get rid of all the VEGF load that is there inside, and only then you can sort of move on to either 2 monthly or 3 monthly. So you can see that the subretinal fluid has come in, and after I injected Pagenex, the SRFS again vanished within 10 days time. This was my second case where, it is just like a pachychloride. You can see there is sub-RP fluid, and the vision was 6/12. I injected injection Pagenex, and within a week, can see a superb drying effect. Most of the fluid is gone, and the vision has improved to 6/9. So I feel we have to be thankful that we got this molecule now, but we have to be also careful because this molecule has reported some amount of intraocular inflammations in patients after injection. So if you want to make this as your drug of choice, you have to rule out any prior ocular inflammation. You have to look out for signs for any old iritis, iridocyclitis, or vasculitis. So you have to look at the retina very thoroughly. And only if you find signs of no previous ocular inflammations, then you should go ahead and inject. Thank you.
Thank you, sir. So just for the benefit of the audience, I would ask some pointed questions. I know you both have covered it in your talks, but just to make it clear, what are your present indications to start brolucizumab? First, Prashant sir and then Nishi sir. Even if you have had a small group of patients till now, what is your line of thinking for future? When would you initiate it? Therapy of brolucizumab.
Basically, at this point of time, as I said, one was treatment naive and one was a patient who was already, I have 2 patients on my roll call. I have injected about 4 injections, means 2 each in each patient. One had a significant fluid. I had to tell him a treatment naive patient. I thought he would have got of communities there a bridge, and we gave him an option like we give option of various anti-VEGF molecules, and told him this is a newer molecule which probably in a long term might need 3 monthly after initial 3 loading dose. So you can save upon money. Yes, there is something, there are some reported indications of inflammation. Patient was quite, means his son was in US, and so he knew something like that is, and so he went on the net and he said, okay, sir, doctor, we would like to go for that. While my choice where I pushed upon that injection was a patient who was already on multiple anti-VEGFs and who was having a drying effect, and then again he would recover back. And so we were really on an average injecting 5 to 6 injections in a year. So with him, I spoke to him, we can have a choice where we can bring down the number of injection that patient. So the other patient is a resistant or a recurrent type of one.
Nishi sir, your present indication.
So my first indication, I would go in for either patients who are resistant to your treatment that is going on. And when I'm going in for a naive case, I would be very sure that the eye is a very clean eye. There is no previous ocular inflammation. And I would rather go in for a very compliant patient. Because see, this is a new molecule, and I want the patient to come back to me if there is any sort of, you know, any outside the
Adverse event.
box symptom that the patient has got. So I'm looking out for patients, even if they're treatment naive, for someone who is a very compliant, a very educated, and a person who can make a informed decision about the anti-VEGF that he's taking, so that he can report to you, even if there is a slightest problem, even if it doesn't mean anything. But I don't mind seeing him at that time again, just to rule out anything at all. Because it's a new molecule and we have to learn how to use it till we get like used to using this molecule, because it's a fantastic molecule, but we have to use it with good care.
So, like everybody of us, we present a bouquet of agents to all our patients. And the selling point or the USP of ILIA is the strength of the molecule, is the number of receptors in it. Would you agree that the strength of brolucizumab is its efficacy as well as the 3-monthly? So is that something like a USP, a selling point for convincing a patient that once he fits into our inclusion criteria, we can promote it in the case where, just like how we did it with Ozurdex, that this particular drug, if it is successful in your eye, probably you just need 3-monthly later on. Is it so? Would you agree with that?
Yeah,
So there
exactly.
are two USPs for this. One is the drying effect, and second is the prolonged action. I mean, these are the two things that sets this molecule apart. So, if you're not going to get a good amount of drying with any agent that you had before, then you might as well go in for this agent to dry it. And of course, if you want the patient to be having lesser injections, which we are going to look at. So when aflibercept came in, most of us were happy because we had a molecule which was 2-monthly. So, the longer duration of the action means lesser visits. And plus, this molecule is very well priced. It's economically priced, just about 24,000. So economic burden also is less for the patient. So, you can imagine a less economic burden molecule with less visits is the USP with a better drying capacity.
Yeah, for me, Swapnesh, the basic thing is, if I look at it at a setting like a smaller economically backward zones like Nagpur, where we charge about 7,500 for an anti-VEGF like Avastin, where we always have a looming threat of having some legal complications. There also 3 injections means almost 24,000, 25,000, plus the number of visits, the number of OCTs. While if you come down to this molecule where we charge 5,000 plus the procedure as a procedure cost plus the price of supply to us, so it comes to around 28,000-29,000 in our setup. So the patients are definitely going to pick up for the price. And the second thing is the less number of injections. And that's what I said, one of my naive patient who was economically not very strong could pick up that. And he was well informed as well. Definitely we need to look at it. He is well informed and he can understand the implications of it, as already Dr. Nishi has spoken about it. But he looked at it in our area, definitely economics make a difference. And definitely less visits, less number of injections, and the pricing with which brolucizumab Paganex is placed, it would definitely be in one of the molecules in my kitty which I would be offering once I develop a confidence over the molecule in next 6 months.
Last 2 questions. One is out of the box question. Suppose theoretically a patient comes to you who is on prostaglandin analogs, who is a glaucoma patient. Would this be your choice? I'm just thinking from the inflammation point of view. We have talked about inflammatory CNVM, or in any case, as sir put it, not a clean eye, but a clean eye with who is already on prostaglandins.
Not at this point of time for me. It might be a year down where I become more confident how do I control an inflammation, because hearsay believing an inflammation which can be controlled, because for me the biggest question is, if ever I have an inflamed eye, how would I differentiate between a sterile versus an endo? That is the first question looms. So once I know how to differentiate that in a few cases or hear, say, from other people, other colleagues like Nishi and you people, then I would be more pushy about in difficult cases.
So, Swapnish, I have spoken to a few glaucoma specialists, and they don't believe in this prostaglandin analog theory. So I've clearly asked them, whether you need to stop it prior to a cataract surgery or anything like that for prevention of CME, and their answer is no. I mean, they said that it is just quite theoretical. And so if I don't find any ocular inflammation that is active and no signs of previous ocular inflammation, I'm not going to think much about that.
So
That's Nishi.
So Prashant sir gave me a clue for my last question, that obviously we have seen case reports about some inflammation regarding these molecules. Could you, both of you, if you have discussed with your colleagues, could you give us some salient features of inflammation typically associated with this particular injection? Any clues, or how does it mimic?
Yeah, that's what yesterday we had the same discussion, me and Nishi, over one of the platforms. Same thing again. The inflammation is predominantly means lesser in intensity, less red eye, less angry looking eye, and usually whatever the Hawk and Harrier study has quoted is the inflammation presents quite later, 2 to 3 weeks down. It's not immediately. So to learn from them, if you have an inflammation on a second day, whether you can't learn from the whatever the study has given spoken about the arthritis part of it and the vitreous inflammation. So that part is again a gray area where you have to keep your fingers crossed. If you have an inflammation on a second day, for example, is it the inflammatory part or is it an infective component? I think Hawk and Harrier has not yet addressed that issue. Rather, those inflammations are not taken, it's not the thing which they talk about with this molecule.
Yeah.
Were
So typically
oral
most of
steroids,
the
were oral
sorry,
steroids used?
no, Swapnesh, so most of the inflammations were seen, majority were up to 3 weeks or after 3 weeks of injection. And most of the inflammations were common in the first 6 months of you starting the injection. So it is not only the first injection that can give rise to it. You can even get it with the second or the third injection. And in the first 6 months, you can get inflammation. Now the inflammations can range from range from just a mild amount of vitritis to severe vitritis. And if this inflammation is unchecked, then it can go into a severe inflammation and then lead to vascular occlusions and those things that we have seen. So the advisory when it came in that as soon as you get an inflammation, you start with steroids. So if it's just a mild inflammation, you can give either topical or subtenance. If it's more, then you can go ahead and give intravitreal. And if it goes to the vascular level, then people have even gone ahead and given IV methylprednisolone. So this is the thing, and that's why you want your patient to be aware and to reach to you early, so that if you control the inflammation faster, you are not going to reach the level of vascular occlusion. And you have to be careful till for the first 6 months, and that's most important. And that's why you need a very compliant patient and an educated one.
How would you advise if a surgeon has injected brolucizumab about a month back and he sees inflammation in the 6th week? What would be your management protocol? Would you wait for the inflammation to grow till you start systemic steroids, or would you be very aggressive and just start it immediately, because you yourself said that you don't want to go it till the stage of vasculitis?
You have to be aggressive, Swapnesh. Whenever you see an inflammation that comes in later and you know that it is not infective, then you have to be aggressive and get down the inflammation, because we don't want it to progress at all. So frankly, even if they are said topical and if the patient is non-diabetic, I would rather go with oral steroids or even posterior subtenance and just try to stamp out the inflammation as early as possible, as much as I can.
In the few cases which have been reported in India and abroad, was vitrectomy anytime required, if at all it has come to in literature?
So until now, only one inflammation has been reported out of the 200 odd injections that they have given. And that patient was operated on, the report presented on the after about 12 hours or so. And within 2 months, within 2 days, the patient underwent vitrectomy at LV Prasad. Dr. Raja was managing. So the last I heard, the patient is doing well, out of inflammation, and has come back to the visual acuity pre-injection what it was.
The basic question over there is, see, according to Hawke and Harrier studies, this all inflammations were late onset. While the case which has been reported from our country is immediately post-op, rather I should say within 24-48 hours. Now, should we in this particular context follow the recommendations of Hawke and Harrier studies, or like pumping with steroids, or should you rather think in more in favor of infective, and should you blame the molecule is another point of debate. Because immediately within 24-48 hours, if we trust the trials, I would not implicate it to the molecule per se, I believe. I would think it more as an infective and treat it like an infective. Might be along with it, I might add steroid right from the first intravitreal dose which I give to the patient. That is how I would look at it.
Absolutely.
So I think we are on time, and last closing remarks by both of you. And I would thank again Novartis team for coordinating all this, and an excellent lecture before all this coordinated by Dr. Himanshu regarding the insurance aspect. And thank you both of you. Over to last closing remarks by Borse sir and Prashant sir.
Prashant, you first.
Yeah. The thing is, yes, this is a new kid on the block. One should not really shy away from it. We need to trust the various trials which have been done quite fairly. That is what we feel. And definitely in a country where we are placed like India, where economics work, where compliance is a issue, a molecule which will has a better penetration, better fluid effect, needing less visits, and we can definitely try it, yes, with a caution, as already pointed out by Dr. Nishikant.
Yeah, so it's a good molecule, but like every good thing, there's also a flip side to the coin. So it was in form of inflammation. So even if it is very less, so after the advisory of ruling out intraocular inflammations has come in, the amount of IOI have gone down drastically. And so we have to go back and not just focus on the macula. If you want to shift over to this molecule, do a good indirect ophthalmoscopy, rule out peripheral vasculitis, intermediate uveitis, and then you can safely use this molecule and give better results for the patient. So it is very important that we choose our cases carefully and let the patient make an informed decision about it.
Thank you, thank you. Soon after 2 months, we would look for 100 injection evidence from both of you. And thank you for joining in.
There. Thank you.
Thank you all, and thank you Novartis team, and have a great Sunday. Thank you all for joining.
Thank you.
Thank you very much.
Thank you.